there. All right, today's lecture, Lung Cancer Management in North Carolina, Updates in 2020 with Dr. Patel. So we are very excited about this. Dr. Patel, as an MD and PhD Assistant Professor of Medicine in the Division of Hematology Oncology at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. She specializes in seeing patients with thoracic and head and neck cancer. She obtained her MD and PhD at the University of Pennsylvania, studying cancer biology. She then completed a residency and training in internal medicine at Brigham and Women's Hospital prior to returning to University of Pennsylvania for a fellowship in medical oncology. She has a particular interest in translational research related to immune and targeted therapies, bringing laboratory findings to the clinic to develop novel treatments. She also serves as a molecular tumor board member and for the ASCO Targeted Agent Profiling and Utilization Registry and the UNC. Today, what's something that I left off of there? Maybe something that rounds out your interests.
Well, thank you for that kind introduction. I have recently discovered the beautiful North Carolina mountains, which is a good way, I guess, of social isolating. So that's been a fun, treat recently, the western part of North Carolina.
Great, good for you. They are amazing. As I was picking a background for today, I decided to pick the California, just in thinking about. And I actually grew up out there, but thinking about the horrendous fires that are out there, and just thinking about everything everyone's going through, and the beautiful landscapes that are on fire there. It's but definitely our thoughts are with the folks on the West Coast. Let's see. So here's our first question. Which of the following is not a risk factor for lung cancer? And this will pop up in a minute, but A, smoking or exposure to secondhand smoke, B, exposure to radon gas, C, HIV infection, or D, exercise and healthy diet. Now, for those of you who have joined us before, you know that our first question is kind of a softball. So, but go ahead and take your best guess. These are all anonymous. And we'll pop that up in a minute, but I do need to do our disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Shetal Patel, MD, PhD, receives research support from AstraZeneca and has no other relevant financial relationships with commercial interests as defined by the ACCME. And here is that poll question. So we've already had several folks answer, so thank you. So take about 10-15 more seconds to go ahead and put in what you think is the correct answer. Again, the question is, which of the following is not a risk factor for lung cancer? And if you think that's A, smoking or exposure to secondhand smoke, put that in. B, exposure to radon gas. C, HIV infection, or D, exercise and healthy diet. And Dr. Patel, I'm already seeing a trend here. How are they doing?
That's pretty good, yeah.
Okay. So all of those others, the smoking, the radon gas, the HIV infection are risks. All right. So without further ado, lung cancer management in North Carolina, updates for 2020. And Dr. Patel, take it away.
Thank you, and thank you all for joining us today. It's exciting to talk about some recent updates in lung cancer. And today I'll be focusing on systemic therapies in advanced or metastatic lung cancer, as unfortunately that's the stage where most of our patients present. But I should mention that we're also seeing some of these improvements coming into earlier stages of lung cancer with targeted therapies and immunotherapy moving into the adjuvant setting as well. Next slide, please. And these are my disclosures, as we mentioned. Next slide. So as I mentioned, we'll be focusing on advanced or metastatic lung cancer, and the learning objectives for the talk today will include recognizing biomarkers for selecting targeted therapy for non-small cell lung cancer, comparing immune checkpoint inhibitor treatment options, and then Also describing the role of immune checkpoint inhibitors in small cell lung cancer. Next slide. And to just briefly outline the talk, we'll be focusing first on molecular testing approaches and then going over some of the newer targeted therapies that have been approved in non-small cell lung cancer. And then talking a bit about some of the emerging targets, which we hope to see in the next couple of years. And then I'll review overall, immunotherapy approaches in lung cancer, and then review the newer combinations that have been approved in the past few months. And then finally end with small cell lung cancer, the role of immune checkpoint inhibitors there, and then also a new approval of an agent in the second line setting. Next slide. So to start with our case, BT is a 70-year-old female who's a non-smoker, has a past medical history of hypertension, and presents to her primary care doctor with swelling in the left neck for 2 weeks. A CT scan of the neck is obtained and reveals supraclavicular lymphadenopathy. And to further evaluate that, the patient has a CAT scan of the chest, which demonstrates a dominant left upper lobe mass, as well as lymph node involvement in the mediastinum and bilateral lung nodules. She's referred to interventional radiology and has a core biopsy performed of that supraclavicular mass. And the pathology demonstrates a non-small cell carcinoma consistent with a lung adenocarcinoma, with the immunohistochemical profile there being consistent with adenocarcinoma. Next slide. So to briefly review, as we all know, when we think about the categories of histology for lung cancer, the two main buckets we think about are small cell lung cancers and non-small cell lung cancers. And then in the non-small cell lung cancer group, adenocarcinomas, squamous cell, and large cell make up the predominant additional histologies. In thinking about the initial diagnosis and workup of adenocarcinoma, we've learned that molecular profiling is a very important part of the initial workup, as it can be an important guide to deciding on therapies for patients like our patient BT who presents with metastatic disease. Next slide. So molecular profiling approaches for lung adenocarcinomas include tissue-based profiling to look for genetic mutations, which can include next-generation sequencing that can be performed on DNA samples taken from the tissue biopsy or RNA specimens. And next-generation sequencing refers to large-scale panels that look at a broad array of genes by an untargeted approach. Additional approaches to looking at specific mutations include using a polymerase chain reaction, fluorescence in situ hybridization, as well as certain specific immunohistochemical studies that can identify specific mutations. In addition to the tissue-based testing approaches, we also now have the option of using blood-based or liquid biopsy approaches to identify some of these mutations through plasma samples in patients. And that can be an important adjunct if tissue-based approaches do not have adequate sample material. Next slide. So while we initially were thought of non-small cell lung cancers and lung adenocarcinomas as one bucket, as more mutation and genomic profiling has been done of these malignancies, we've learned that they actually represent a number of distinct molecular subtypes. And fortunately, in lung adenocarcinomas, the number of targetable mutations that are applicable in these patients has continued to increase as agents that can target mutations have improved. So this pie chart here shows the mutations that we can find in lung adenocarcinoma patients. And as you can see, the most dominant mutations typically are KRAS mutations and EGFR mutations, but there's a host of other mutations that we can observe that are now actually targetable with specific tyrosine kinase or other inhibitors that can actually focus on the mutations that are found in the patients. So other mutations that have first-line targetable indications include BRAF mutations, ALK fusions, ROS1 fusions, and NTRK fusions. And as we'll discuss further in later portion of our talk, some emerging targets including MET and RET, which have had new approvals recently. Next slide. So our patient has a biopsy specimen that is submitted for DNA-based next-generation sequencing, but has insufficient material to perform the sequencing on that biopsy. So the patient is then referred to have a liquid biopsy based off of blood. And on the blood analysis, which is based off of circulating or cell-free DNA, a MET exon 14 mutation is identified. As part of the initial workup, the patient also has immunohistochemistry performed for PDL1 with a specific assay, the 22C3 assay, which demonstrates a tumor proportion score of 20%. And we'll get back to discussing the implications of that as well. So what therapy choices does this patient have? So next slide. This case example is to illustrate a couple of things. One, that the use of the blood-based biomarker testing is an option for patients that can't have adequate tissue-based testing. One question that always arises with blood-based testing is what's the concordance and sensitivity of that assay relative to tissue-based testing approaches? And when people have looked back, there's variable sensitivity of the tissue blood-based assays, which depends on the degree of shedding of the tumor DNA as well as the overall tumor burden of the patient, but ranges of 60 to 90% have been observed. Importantly, though, there does appear to be a high concordance rate between tissue-based testing and blood or plasma-based testing for specific driver mutations, which we would use to select targeted therapies for patients. And this has allowed plasma-based testing to be an important adjunctive approach both in initial diagnosis of patients as well as a way to use in longitudinal analysis to identify potential mechanisms of resistance to targetable mutations. There are some challenges that remain with these plasma-based approaches because you're sampling overall mutations in the blood. You can't specifically look at mutations in a particular site, so it's difficult to know if a mutation may be subclonal or not present at all the tumor sites in the patient. Another challenge of blood-based approaches with the current commercially available assays is that you really can't distinguish whether the mutation you're seeing is truly from the tumor or could be present in other cells in the body. And what we're learning as we use these assays more and more is that we do have mutations that arise in our white blood cells as patients age and are determined clonal hematopoiesis of indeterminate potential, which may not necessarily be mutations present in the tumor that you're targeting. But these approaches are important and they provide a nice adjunct for patients like ours that don't have the ability to get tissue-based testing at the outset of treatment. Next slide. Other thing that we've learned is that in prospective profiling of plasma mutations on blood, when we target patients with agents based off of these mutations, they can have good outcomes similar to tissue-based targeting. So what I've shown here is data from using osimertinib, which is a third-generation EGFR inhibitor, and looking at the ability of either tumor mutation testing or plasma mutation testing and how well it corresponds with response rates. So you can see on the left with tumor-based mutation testing and plasma-based mutation testing for a specific resistance mutation, T790M, which is targetable by osimertinib, you can see high response rates when the mutation is found in both of those approaches. So at least for some of these driver mutations, finding it either in the tumor and the plasma can lead to good options for the patient in terms of treatment. So returning to our patient, next slide. The MET mutation that was identified is in a receptor tyrosine kinase, which has been found to have mutations in about 3 to 4% of patients with lung cancer, non-small cell lung cancer. The MET gene is a receptor that can be activated both by ligand activation, but also by either mutations or genomic amplification. So specifically, this exon 14 skipping mutation leads to loss of a portion of the protein that leads to constitutive activation of the tyrosine kinase that can activate a number of pathways that promote cell proliferation, survival, motility, and other processes that are important in tumorigenesis. And in previous studies, activation of the MET pathway has been associated with poor responses to standard chemotherapies and immunotherapies. Next slide. So importantly, as we think about treatment options for our patient, the recently presented geometry study looked at an agent called capmatinib, which is a selective MET inhibitor, and its activity in patients that had MET exon 14 mutations. And so the data on the slide here is showing outcomes from 2 cohorts in this study. One, cohort 4, which included non-small cell lung cancer patients that had a MET exon 14 mutation and were treated in either the second or third line settings, and a second cohort of patients, cohort 5, which were treated in the first line settings. And as you can see in these response waterfall plots, both patients that were treated in more advanced lines as well as in first line had good responses to this agent with durable and deep responses observed in those patient populations. Next slide. In addition to the response rates, there also appeared to be relatively durable responses with this agent, as you can see from these swimmer's plots, both in the second as well as the first line setting, with encouraging progression-free survival and duration of response. So the outcomes of this study have led to the approval of capmatinib as an agent for the targeting of MET exon 14 mutations in patients such as ours. And this was recently approved. Next slide. Another target that was recently found to have a new inhibitor for non-small cell lung cancer is RET mutations. So RET is another receptor tyrosine kinase that can be activated by fusions or point mutations. In non-small cell lung cancer, the most common mechanism of activation is fusions, with the partners listed here, particularly the KIF5B. RET fusions are found in approximately 2% of non-small cell lung cancers and can be seen in a number of other tumor types as listed here, most prominently in papillary and other thyroid cancers. Next slide. So RET fusion proteins lead to activation of the kinase, and selpercatinib is a novel RET tyrosine kinase inhibitor that has been shown to have significant activity in RET fusion positive non-small cell lung cancer. So the data on the slide shown here is from the Libretto study, which was a phase 1/2 study of selpercatinib that included multiple patient cohorts, and I'm showing the data here from non-small cell lung cancer patients. And what you can see is in RET fusion positive non-small cell lung cancer, both in patients that had previously been treated with platinum-based doublet chemotherapy, which would have been the prior standard of care. You could see high response rates, a response rate of 64%. And as well, patients that were treatment naive were included in this study. And in those patients, there was an even improved overall response rate of over 85%. And encouragingly, the duration of response with these inhibitors has also been prolonged with anywhere from 18 months in previously treated patients to not reached in treatment naive patients. Another advantage of the tyrosine kinase inhibitor is that in contrast to standard chemotherapy, this agent also has intracranial activity. So patients with brain metastases were shown to have shrinkage of their tumors with this agent in the clinical trial. And this data from the Libretto study led to the approval of selpercatinib for patients with RET fusion positive non-small cell lung cancer. Next slide. So our question is, which of the following genomic alterations do not currently have FDA-approved therapies in non-small cell lung cancer? MET exon 14 deletion, KIF5B RET fusion, KRAS mutations, or ROS1 fusions?
And take just 10-15 seconds, if you would, to go ahead and submit your answer. Again, these are all anonymous, so we'll wait just a few more seconds. Again, like the first one, we seem to have a trend here. Dr. Patel, which answer were you looking for?
So as everyone in the group has gotten, KRAS has been one of the mutations that we don't have a targetable agent for yet. But as we'll talk about in the next couple of slides, there is promise that KRAS will hopefully become one of the mutations that we have a targeted agent for in the future.
Great. Thank you so much.
So for our patient, then capmatinib would be an FDA-approved therapy that would be able to use for the MET exon 14 deletion. So those two approvals are encouraging and offer new treatment options for our lung adenocarcinoma patients. I wanted to spend a little bit of time talking about some emerging targets for these patients as well. So as you all saw with that previous question, KRAS has been one of the mutations that is commonly present in lung adenocarcinomas, but to date hasn't been able to be targeted with selective inhibitors. And we're hoping that will change over the coming years as a number of agents are actually entering clinical trials or in clinical trials currently. So I'm going to specifically talk about mutations in KRAS at the G12C location, as there are several inhibitors that are currently in early phase clinical trials. These agents are orally bioavailable, irreversible inhibitors that bind KRAS G12C and maintain it in its inactive GDP-bound state. Here I'm showing specifically some anti-tumor activity of MRTX849 in preclinical cancer models that have the G12C mutation. As you can see here, in terms of the tumor response across a number of different tumor types with that specific KRAS G12C mutation, you can see decreases in lung cancers, colon cancers, as well as pancreas cancers in preclinical approaches. And concomitant mutations in genes such as P53, KEAP1, and STK11 do not appear to predict response to this selective KRAS G12C inhibitor, which is encouraging because patients with these mutations have often had poor outcomes with standard chemotherapy or immunotherapy. And so these agents are now in early phase 1-2 trials, as well as entering combination trials. And I'll highlight just a little bit of data from the MRTX849 agent, which is in phase 1-2 trials, including a trial that is currently open here at UNC. Next slide. So, if you could go back one, great. So the MRTX849 is in phase 1-2 trial. It has gone through the phase 1 portion and has an established dose of 600 milligrams twice daily. And here I'm showing some data that was presented at last year's AACR meeting showing early activity in colorectal cancer patients as well as in non-small cell lung cancer patients. So this is a small cohort, but that you can see there was encouraging responses in patients with non-small cell lung cancer with this agent, with a response rate in 3 out of 5 patients and a disease control rate in all patients seen in this small study. Next slide. And here is just a case example of a patient that was on this clinical trial demonstrating the type of clinical responses patients can see. This was a woman with a history of a lung adenocarcinoma, a former smoker that was found on molecular testing to have a KRAS G12C mutation, as well as mutations in KEAP1 and STK11, and had gone through a number of different lines of therapy, including chemotherapy as well as immunotherapy, and then was initiated on this clinical trial. And as you can see from the CT scans shown here, the patient had a very significant both imaging as well as clinical response to therapy with improvement in symptoms soon after starting therapy. So this is an encouraging drug that we hope to see being able to be used for more patients with KRAS G12C mutations and also in combinations that hopefully will improve the durability of responses that we see. Next slide. So another potential target in lung adenocarcinomas has been activating mutations in HER2. HER2 is also another receptor which in non-small cell lung cancer has been found to have activating mutations in 1 to 3% of patients, which is in contrast to breast cancer where it's often activated by amplification of the gene. Because of the nature of some of these mutations, they haven't been well targeted with standard tyrosine kinase inhibitors, but there were some encouraging results that were presented at this year's ASCO with a novel antibody drug conjugate, trastuzumab deruxtecan, which includes HER2 and an antibody linker to this topoisomerase I inhibitor payload. If you could advance. So this agent was tested in patients with non-small cell lung cancer with activating HER2 mutations and found to have a response rate of over 60% and also a progression-free survival of over 14 months, which is really encouraging for targeting HER2 mutations, which previous to this have not had good activity with tyrosine kinase inhibitors in non-small cell lung cancer. Next slide. And this is just the waterfall plots from that Destiny lung study that was presented at ASCO, showing that while in a small cohort of patients at this time, there was encouraging decrease in tumor that was seen across a number of different patients. Next slide. So switching gears a little bit from targeted therapies in patients that have specific driver mutations to immunotherapy, we've seen over the past years that immunotherapy has really dramatically changed the treatment landscape and overall prognosis of patients with lung cancer. And so wanted to go over a few of the updates in terms of the novel combinations that have been approved in the past few months. Taking a little bit of a step back as we think about how immunotherapy works, the development of an anti-tumor immune response is really a pretty complicated and multi-step process. As cancers grow and divide, they can have cell death, which leads to uptake of some of the tumors by antigen-presenting cells, such as dendritic cells. And these dendritic cells can present abnormal proteins in tumors in the context of class I MHC, which can lead to the activation of T cells. In addition to the activation of T cells by dendritic cells, as this interaction is happening, inhibitory receptors on the T cells, such as CTLA-4, can also be upregulated. And these inhibitory receptors are normally present to curb the immune response, but in the case of cancer, these can prevent the immune response from being able to recognize the tumors. So CTLA-4 was one of the first inhibitory receptors that was targeted clinically with an antibody called ipilimumab. And the concept is that by inhibiting the interaction of this inhibitory receptor on the T cell during the early immune priming stage, you may be able to improve immune responses. And the antibody that targets this, ipilimumab, was one of the first checkpoint inhibitors approved in melanoma. Another inhibitory receptor that's present on T cells is the PD-1 receptor. PD-1, when it's engaged by its ligands, PD-L1 or PD-L2, also leads to decrease in T cell function. The ligands for PD-1 can be present on both tumor cells as well as immune cells in the tumor microenvironment, such as macrophages or other immune cell types. And when the PD-L1 ligand is engaged by PD-1, that can lead to exhaustion of T cells so that they are not as functional. Importantly, what we've observed from our studies with antibodies that can block PD-1 or PD-L1, that you can actually reverse that T cell function to a certain degree, and that can allow these T cells to have improved activity and clear the cancer cells. So this has been a real advance in the treatment of non-small cell lung cancer with both PD-1 and PD-L1 agents now approved at various stages of treatment. Next slide. That underlying mechanism of action of immunotherapy is also important for understanding how we develop biomarkers for selecting what agents are most appropriate for patients. So currently, the most widely used biomarker for non-small cell lung cancer for selecting patients for immunotherapy is PD-L1 expression by immunohistochemistry. So PD-L1 expression can be looked at on the tumor cells, and that's the most commonly used approach in non-small cell lung cancer, and that generates a score called a tumor proportion score, which represents the percentage of tumor cells that are positively stained for PD-L1. And this can be used to select patients for both immunotherapy alone as a first-line treatment option or in combination with other agents, as we'll go through in the next few slides. One of the challenges of PD-L1 as a biomarker is that it can be different based off of the tumor site that is selected for staining, and there were a number of different antibodies that were developed by different companies as they were developing their drugs that may have different staining properties. There's been a pretty concerted effort to look at the concordance of those antibodies across different tumor samples, and that's helped inform the reliability of these assays. And PD-L1 is the most widely used biomarker currently for selection of patients for immunotherapy in non-small cell lung cancer. Another biomarker that is commonly thought about is tumor mutational burden, which looks at the number of mutations that are present in the tumor as a surrogate marker for the number of different antigens or abnormal proteins that may be present and be able to be recognized by the immune system as foreign. Currently in non-small cell lung cancer, tumor mutational burden is continuing to be explored, but is not used as frequently in the frontline setting to select patients for therapy. And both of these biomarkers really suggest that patients currently that we select for PD-1 or PD-L1 blockade are those patients that seem to have an immune response against the tumor that we're trying to get reactivated again, because these markers represent tumors that may be inflamed at the outset. Next slide. So this slide summarizes a number of the different immunotherapy agents that we have approved. So there are several different antibodies to PD-1, pembrolizumab and nivolumab, which both have roles in non-small cell lung cancer, and cemiplimab. And then PD-L1 antibodies, including atezolizumab, durvalumab, and avelumab. And then for CTLA-4-directed antibodies, ipilimumab is the one that is currently approved, and tremelimumab has been looked at in a number of different studies. Next slide, please. So in non-small cell lung cancer, using PD-L1 as a stratification approach, patients that have high PD-L1 have the potential to be treated with immune checkpoint blockade alone with pembrolizumab or atezolizumab. And usually 50% or greater is a cutoff that we use to select for monotherapy with immunotherapy. But for patients that have lower PD-L1 scores, we oftentimes use a combination of approaches. And I'll go through some of the newer data on combinations of nivolumab and ipilimumab. But before that approval, the combination that we were commonly using was a combination of chemotherapy as well as immune therapy. And here I'm just summarizing the combinations that are approved in non-squamous cancers or adenocarcinomas, which include carboplatin, pemetrexed, and pembrolizumab, as well as carboplatin, paclitaxel, atezolizumab, and the VEGF antibody bevacizumab. And then in squamous cancers, combinations of carboplatin and paclitaxel with pembrolizumab, or carboplatin and nab-paclitaxel. And then in the next couple of slides, we'll go over the newer data for nivolumab and ipilimumab. Next slide. So before we go to that, a poll question: which biomarkers are used to select non-small cell lung cancer patients for immune checkpoint blockade?
All right, and again, take maybe 5 more seconds. Do you mind, Dr. Patel, reading the answers? Because I know you'll do a better job with the pronunciation than I will.
Yes, so the potential choices here for biomarkers are PD-L1 expression by immunohistochemistry, T-cell inflamed gene expression profiling, mismatch repair deficiency, or EGFR mutations.
Great, thanks. And immunohistochemistry. See, I would have had that one. Oh, well. All right, so how did they do with A? Is that what you were looking for?
Yeah, so as the group has sort of unanimously chosen, PD-L1 immunohistochemistry is the marker that we use currently for selecting patients for treatment approaches for non-small cell lung cancer. T-cell inflamed gene expression profiling has been utilized in research studies, but is not something that we use clinically at this point. And mismatch repair deficiency is a potential biomarker in other disease types, but not commonly present in non-small cell lung cancers. And EGFR mutations are a selection biomarker for patients for targeted therapy, and actually is a negative selection marker, generally speaking, for immune checkpoint blockade, as patients with these targetable mutations have found to not have as significant activity with immune checkpoint antibodies.
Great, thank you so much.
So we can go to the next slide. And one more click if you don't mind. Oh, sorry. Go back one more. Oh, I'm sorry, the figure here is not showing up for some reason. But that previous slide of the combination of nivolumab and ipilimumab had the data from the Checkmate 227 study, which led to the approval of that combination in patients with non-small cell lung cancer and a tumor proportion score of greater than 1%. And that study looked at comparing the combination of these two immune checkpoint antibodies that work on two different stages of the immune response and comparing them to chemotherapy, which at the time of initiation of these studies was the standard of care for patients with metastatic non-small cell lung cancer. And what the Checkmate 227 study showed was that in patients with a tumor proportion score of greater than 1%, there was an improvement in overall survival with the combination of these two immune checkpoints compared to chemotherapy. But because the comparator arm in these studies was chemotherapy, the challenge comes in what do we do with patients now that we know that chemotherapy plus PD-1 antibodies also has significant activity in the frontline setting. Since that wasn't a direct comparator in these studies, that's where the question of application of this data comes in. When we think about the use of checkpoint inhibitors, generally speaking, the combination of checkpoint inhibitors tends to have a higher toxicity profile, although the doses that have been used in the lung cancer studies have been lower than the doses that were used in melanoma, which has improved some of the tolerability of these combinations. But because of the lack of direct comparison, the choice of whether to do nivolumab plus ipilimumab versus a chemotherapy plus immunotherapy combination is still an open question. And as we continue looking through some of the additional data on these combinations, we'll discuss some factors that can be used to select patients. But that study, the Checkmate study, led to the approval of the combination of nivolumab and ipilimumab in patients with a tumor proportion score of greater than 1%. Next slide. In addition to that approval, there also recently was the Checkmate 9LA study, which looked at the combination of nivolumab, ipilimumab, as well as 2 cycles of chemotherapy as the first-line treatment for patients with stage 4 non-small cell lung cancer that lacked prior systemic therapy or have sensitizing mutations such as EGFR and ALK. So this study randomized patients to these 2 treatment approaches, and the primary objective of this study was to look at overall survival with stratification by PD-L1 level. And the data from this study was presented recently at ASCO in 2020. Next slide. So this slide summarizes the overall survival that was seen in that data that was presented, which compared again the combination of 2 immune checkpoint inhibitors to histology-based chemotherapy to chemotherapy alone. And as you can see here, the combination of the immunotherapy plus chemotherapy had improved overall survival outcomes relative to chemotherapy alone. But again, the challenge is that this study did not include a comparator arm with checkpoint of PD-1 blockade plus chemotherapy, which has been approved and widely used in the frontline setting in non-small cell lung cancer. And so the question is whether the dual checkpoint inhibitor plus chemotherapy really adds to that. And I think future studies that select based off of additional biomarkers will help us delineate which patients may be most likely to benefit. But the study, the 9LA study, did lead to the approval of this combination as a treatment options for patients in the first-line setting. Next slide. So we can see from these past few slides that really we have multiple first-line treatment options for patients with non-small cell lung cancer that lack a targetable mutation, which is great. So how do we choose between these options? So there's a number of different patient considerations as well as disease considerations to take into account. In thinking about patient factors, patients' performance status or their functional ability is an important consideration. And then there may be important considerations in terms of their preferences. Are you going to choose a first-line approach that has chemotherapy plus immunotherapy if the patient has an intermediate tumor proportion score? Or would you consider choosing a dual immune checkpoint antibody in a patient that had a strong preference of avoiding chemotherapy? And there may be patient comorbidities that would be an important factor as well, such as neuropathy or cytopenias that may sway you away from chemotherapy combinations. In thinking about disease-specific considerations, the patient's PD-L1 status is, of course, an important factor to be considering. And there are some additional disease considerations, including the distribution of metastases and histology that have emerged from looking at retrospective analyses of some of the previously published first-line setting studies of chemotherapy and immune checkpoint blockade, which suggests that potentially patients with pre-existing liver metastases may not have as much of a benefit from combinations with chemotherapy and immunotherapy, and that also in the nivolumab and ipilimumab combinations, it appeared that maybe squamous patients may have a better response. So those are some of the factors to consider in deciding which of these therapies are most likely to be appropriate for a patient. The other factor is, of course, symptom burden and the need for a response. Because these studies, we were looking at overall survival, which is sort of a long-term outcome, and it's hard to distinguish which approach may be the most beneficial. But combination approaches are likely to have higher response rates. So in a patient that's very symptomatic from their disease, a combination of chemotherapy and immunotherapy may be more efficacious in helping alleviate symptoms if you really need a response quickly, as opposed to a patient that had a lower disease burden where you may have the opportunity to allow immunotherapy to have the time for it to work. Next slide. So those are some additional options now that we have for immune therapy combinations in the frontline setting of non-small cell lung cancer. So we'll now move on to our second case to illustrate some examples of therapies in small cell carcinoma. So BB is a 58-year-old male with a 60-pack-year smoking history who presents with facial, arm swelling, and a cough, and has a chest x-ray that demonstrates increased soft tissue in the mediastinum. This prompts a CT, which demonstrates a mediastinal mass with compression of the superior vena cava and hypodensities in the liver that are concerning for metastases. A biopsy of one of these liver lesions demonstrates small cell carcinoma. Should this patient be treated with immune checkpoint blockade? Next slide. So as we think about the treatment options for small cell lung cancer, one important consideration is whether the patient has limited stage or extensive stage disease, limited stage being confined to the thorax versus an extensive stage where they're spread outside. And in this patient with liver metastases, he had extensive stage disease. So an important study that changed the treatment paradigm for patients with extensive stage lung cancer was the Empower 133 study. If you could click forward, which looked, it looks like that figure is not showing again, but again, this was the data from the Empower 133 study, which showed that the addition of atezolizumab, which is a PD-L1 antibody, to standard chemotherapy for small cell lung cancer, which is a platinum etoposide doublet, improved overall survival significantly and led to the approval of atezolizumab in combination with platinum-based chemotherapy as a first-line treatment option for patients with extensive stage small cell lung cancer. Next slide. And then more recently presented data from the Caspian study also looked at the addition of durvalumab, which is another PD-L1 antibody, in combination with platinum etoposide, as well as the combination of durvalumab and tremelimumab with platinum etoposide in the frontline setting for patients with extensive stage lung cancer. So this study enrolled patients that were treatment naive. Importantly, this patient population could include patients that had asymptomatic or treated brain metastases and randomized to these three treatment arms. And the primary endpoint of this study was to look at overall survival. Next slide. So showing here first the data for the combination of the two checkpoint antibodies, durvalumab and tremelimumab. The overall survival here showed a trend towards improvement, but not statistically significant compared to immune therapy alone. Next slide. And then the combination of durvalumab, the PD-L1 antibody, with a checkpoint antibody showed that there was a statistically significant improvement with adding PD-L1 antibody to first-line platinum therapy. And this data from the Caspian study led to the approval of durvalumab as an alternate option for patients with extensive stage small cell lung cancer. So going back to the question for our patient, is immune therapy an option? Yes, both atezolizumab and durvalumab are options for the addition to platinum-based therapy for patients with extensive stage small cell lung cancer. And unlike with non-small cell lung cancer, currently we don't have biomarkers that select for patients that are more likely to respond to checkpoint antibody therapies for extensive stage small cell. Next slide. As we think about immune therapy at other stages of disease, in limited stage small cell, we'll also be looking at whether the addition of immune therapy after concurrent chemoradiation can improve survival, similar to the outcomes of the Pacific study in non-small cell lung cancer. So this is a clinical trial we have currently open at UNC and across a number of states around sites around the world, which is looking at randomizing patients after they complete their standard of care chemoradiation for limited stage small cell lung cancer to one of 3 treatment arms, either durvalumab, tremelimumab, durvalumab, or placebo for 24 months, and looking to see whether that improves overall survival. So hopefully bringing the advantages of immune therapy that we've seen in stage 3 non-small cell lung cancer patients to small cell as well. Next slide. So if we think back to our patient, that patient was initiated on treatment with immunotherapy plus platinum doublet therapy and then had treatment progression, what would be their next line treatment options? Well, standardly before the recent approval of this novel agent that I'll be discussing, that would have been topotecan. But recently, based off of data that I'll go through here, an agent called lurbinectedin, which is an inhibitor of oncogenic transcription, was approved for the treatment of small cell lung cancer in the second line setting. So lurbinectedin, through its inhibition of oncogenic transcription as well as potential other effects on the tumor microenvironment, is thought to lead to apoptosis in tumor cells. And this study looked at patients that had progressed on prior platinum doublet therapy and were treated with lurbinectedin in the second line setting. And they divided patients up based on whether they had a chemotherapy-free interval of less than 90 days or an interval of greater than 90 days. And what you can see is that in those patients that had an interval of greater than 90 days, they had an encouraging response rate of 45% of patients having partial responses, and an additional 37% having stable disease with a duration of 6.2 months. And then even in those patients that had a less than 90-day interval between their prior therapy and progression, they could see responses of 22% as well as stable disease in other 9% of patients. So this data led to the approval of lurbinectedin as a second-line treatment option for patients with small cell lung cancer. Next slide. Some of the common treatment-related adverse events with this intravenously administered medication include cytopenias, including anemia, leukopenias, neutropenia, and thrombocytopenias, as well as T abnormalities, fatigue, and nausea, vomiting. But overall, a nice additional option for patients in the second-line setting for small cell lung cancer, which has traditionally had, unfortunately, poor outcomes and not many treatment options. Next slide. So returning back to our poll question, for PD-L1 inhibitors, do they improve the response rate to first-line therapy in extensive stage small cell lung cancer? True or false?
All right, and just maybe another 5 seconds, please. All right, Dr. Patel, how are they doing?
So I guess this was probably a little bit of a trick question, and unfortunately I think that was a slide that the figure didn't show up for. So while we've seen improvement in overall survival with the addition of PD-L1 inhibitors, the response rates actually don't seem to increase with adding PD-L1 inhibitors. So the correct answer to this question is actually false. So the approvals are based on improvements in overall survival, but because platinum chemotherapy has a very high response rate, we didn't see an improvement in responses with adding the PD-L1 inhibitors.
Gotcha, understood. Well, thank you.
All right, so to summarize what we've reviewed today, Genomic profiling of lung adenocarcinomas is an important part of the initial management of these patients and selecting for treatments for targeted therapies. And recently, the 2 targeted therapies that have increased the number of options we have include capmatinib for MET exon 14 deleted mutated patients, as well as selpercatinib for RET fusion positive patients with non-small cell lung cancer. And we're hoping that our armamentarium of targeted therapies continues to increase as novel KRAS and HER2 targeting agents have showed encouraging activity in early clinical trials. What we reviewed today was that in addition to the combination of chemotherapy and immunotherapy for first-line treatment of patients with non-small cell lung cancer, there has been recent approvals for combination immunotherapy with nivolumab and ipilimumab, as well as nivolumab, ipilimumab, and chemotherapy for the first-line treatment. What we'll hopefully learn in the future is with comparison approaches and better biomarker development, how do we select patients for each of those treatment options and what patient factors may be most important for doing so. In addition, we talked about PD-L1 antibodies and their role in extensive stage small cell lung cancer with both atezolizumab as well as durvalumab showing improvement in overall survival when added to platinum chemotherapy in the frontline setting, and newer studies that are looking at the role of immunotherapy in limited stage small cell lung cancer as well. And then finally, just to briefly mention that we've reviewed that lurbinectedin is a novel agent for the second-line setting for patients with extensive stage small cell lung cancer. And with that, I'll thank you all for your attention and thank our thoracic medical oncology and radiation group, as well as the pulmonary team and thoracic surgeons, which is a great multidisciplinary team that we work with here. I think that leaves us a few minutes for questions.
That does. So at this point, we encourage you to look on Poll Everywhere and go ahead and submit your questions for Dr. Patel. And I'll be looking to see and approve those as they come in. Let's see. Bear with me, we are still waiting. I'll ask one while we're waiting to see if others come in. You had talked about liquid biopsies towards the beginning of the presentation. Would you mind talking a little bit about what the decision-making process is and when you need to go to a liquid biopsy versus it sounded like there was a preferred biopsy procedure and there wasn't enough information to follow that.
Yeah, exactly. And so the liquid biopsy is a nice adjunctive approach. Oftentimes what we consider the gold standard and what a lot of trials are based off of are identifying mutations in the actual tumor specimen of the patient. But liquid biopsy is a nice adjunct if there's not sufficient tumor material available or the patient has a lesion in a site that's more difficult to biopsy. And so that can be an important adjunct approach. And we found that, as we've seen with the data with EGFR inhibitors and now because liquid biopsy is becoming more commonly used, other trials are incorporating it and looking prospectively at whether identifying mutations by these liquid approaches or cell-free DNA approaches are also as effective in identifying targetable mutations. And when they've looked prospectively in trials and doing these liquid biopsies at the outset, they've also seen that it does seem to help identify a broader number of patients that may be able to benefit from these targetable agents.
That is very helpful. Thank you. And I apologize for some reason and we ran into this last time. It's not allowing us to pop the questions on the screen, but we did have a question for HER2 activating mutations. Any known correlation with HER2 IHC?
Interestingly, actually, they don't tend to correlate, and so you can have an activating mutation that's not necessarily amplified and still have responses to these HER2 antibody drug conjugates And the thought is that maybe these mutations are stabilizing the HER2 on the surface, and that helps improve the activity of the antibody drug conjugates.
Great, thank you. And then another question, are there any studies trying to minimize chemotherapy with a PD-1 inhibitor alone rather than with IPI/Nivo?
There are studies that are looking at other immune checkpoints, and we talked about CTLA-4 and PD-1, but there's actually a number of other inhibitory receptors or activating receptors that are present on T cells, and so there are other studies that are looking at combining different inhibitory receptor antibodies. One that comes to mind is an antibody directed against TIGIT that's being looked at in combination with PD-L1 inhibitors and has shown some encouraging activity. The challenges of these combinations, as we've seen with even the combinations we have currently, is it's been continuing to identify what are going to be the biomarkers for selecting patients to target these antibodies for. And I think that's generally one of the hard questions in selecting patients for immunotherapies across tumor types.
Gotcha. And we'll take just two more here. Is it automatic to test for the markers when NSCLC is diagnosed from biopsy?
So it is not, it depends where. A lot of places don't have reflex testing for all of these biomarkers. It's something that we will order if we find that the patient is found to have an adenocarcinoma, particularly the sequencing approaches. We tend to do reflex testing for PD-L1 expression because it's relatively quick to get done, which is one of the advantages of immunohistochemistry. But in terms of our practice, most thoracic oncologists will get molecular testing on all lung adenocarcinoma patients. And I think that's important to do regardless of smoking status. Smoking status, patients that have a lower history or pack years of smoking tend to have more of these targetable mutations, but we can certainly find them in patients that do have a smoking history, and they can offer another very tolerable treatment approach. So we tend to do the mutation testing regardless of whether the patient has a history of smoking.
Gotcha. Thank you so much. And then the last question we have time for today. Please explain possible mechanism for why lurbinectedin is more effective more than 90 days out from chemotherapy.
Yeah. So it's one of the sensitivity to platinum or first-line therapy in small cell lung cancer seems to be across multiple second-line agents for chemotherapy. So we've seen that with both retreating patients with platinum, then also other second-line agents like topotecan. So it seems to be sort of a general intrinsic chemotherapy sensitivity of the tumors as opposed to lacking sensitivity. So I don't know if it's specific to lurbinectedin or generally across, second-line chemotherapy for small cell lung cancer.
Gotcha. Thank you so much. So let me just go over a few more things here, and then we'll wrap up. We do want to say thank you. First and foremost, thank you, Dr. Patel. This has been fascinating. We really appreciate your expertise and your time today. We also want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund at the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell.